So who's supposed to get the happy birthday wishes today? Whose birthday is it? I know it's somebody's. You just being shy? Okay, never mind. Happy birthday anyway. We all do things a little bit differently, so just a few of the ground rules in terms of the way I do things and whatnot. You'll notice on the LCMS Plus, if you downloaded my lectures or looked at them, there's two versions. One labeled Summary and one labeled Builds. And under most circumstances, I will actually try to number the slides on those. Welcome. Would you like a seat here in the front? I'll show you then. I would recommend not printing them up. If you look at the builds, sometimes the builds represent each click of my pointer here. And that could be, a 30 slide lecture could be 200 slides if you print them up, which is kind of a waste of time. It's really in lieu of Camtasia so that you can listen to the recording and follow through slide by slide at your own pace, and it actually works very well, as opposed to winding and rewinding and trying to listen to things. So there is a purpose behind it. The summary slides actually just kind of help you know where you're going. But with all the slides numbered, it kind of keeps you on track in terms of where the package of information is. The only other request that I make is that you not take photographs of the lecture while we're going on. It's very distracting and tends to ruin the flow of things. Okay, so let's get rid of the lights slowly. Okay, and we have to talk about the thoracic wall. Now, a good part of what we're going to talk about, you've already had an introduction to the principles of this stuff. Is that a little bit too dark maybe? Let's try it one level up. You've already had a good introduction. Nah, that's too bright. Or is it? Yeah, we'll go back down. So we're going to be using the terminology from, say, the previous lectures to introduce newer concepts and go forward. So it really is crucial to stay current in all of this. I would say the biggest piece of advice I could give you, even from this early stage, is never fall behind. So whatever we present to you today, you should review and have down cold by lab tomorrow. All right? And it's not a lot of information. If you think it's a lot, it gets to be a lot worse if you've let a couple of days go by. So staying current is your friend. And you shouldn't sacrifice one subject to study for another. Cramming in this sort of environment does not work. All right? So you need to balance your time. Time management is probably the most important skill to master in all of this so that you can stay current. All right, let's move forward. Let me get that pointer out of the way because that's distracting me too. All right, so thoracic wall. When we talk about the thoracic wall, we have to pick a starting point somewhere. So what I want to do is start with the actual thoracic skeleton. What we have to describe is the structure of the skeleton, the thoracic cage. We then have to go to the muscles that are both outside the cage and intrinsic to the cage. And I'll define what that means as we go along further. So if we let's start with the sternum. All right, you guys had an introduction to the cadavers last Friday. So you've already felt a lot of these landmarks, but now we have to go deeper and show what they represent. The sternum, as you're probably well aware, has three pieces. From superior to inferior, we have the manubrium, the body, and then the xiphoid. I'd say of those three, the xiphoid is the most inconsistently shaped. It can be curled forward, it can be bent to the side, irrelevant, but there's variation. Next, we have the clavicle. Wait a minute. We're talking about the chest cage. Doesn't the clavicle belong to the shoulder? Well, yes, sort of, but it's anchored to the sternum, and some of the muscles that we're going to be talking about are actually anchored or attached to the clavicle itself. A lot of the muscles that are attached to the skeleton at this point are things that we would normally consider with the upper extremity, but they're in the way. And this is the only chance to take a look at them because we have to get them out of the way so that we can get into the chest and look at other things. So we take the opportunity to go through this part of the things as well as the muscles that are coming from somewhere else and then ultimately being attached at some point to one of the structures in and around the thoracic skeleton. Surface features of which you're probably well aware at this point would be that jugular notch, which is the superior aspect of the manubrium, bounded by the medial head of the clavicle on either side, and then the angle of Louis right there, the junction not just between the manubrium and the body of the sternum, but also where the second rib, right, 1, 2, second rib, is joining right at that junction. Now, it's important to keep that in mind because it takes a cooperative patient to come in and bare their sternum to you to give you an idea of where you're looking around. So you should be able to feel your sternal notch on yourself, and that's going to be a reference point for thinking of everything that's just posterior to that line and just posterior to your manubrium. So, for instance, just as a quick fast forward, if I'm talking about this, that's going to be a division between the upper part and the lower part of the mediastinum, which we haven't defined yet. But I know the arch of my aorta is behind there. I know the arch of your aorta is behind there. So when you're examining your patients, if you can feel their sternal angle, you know what's above and below it without even listening or looking. These are the kinds of relationships you have to develop. And that's something that's easily felt in everybody. Doesn't matter about body size. That's something that's easily felt. At this point, as the manubrium goes inferiorly, it's kind of slanted anteriorly, which gives you that sort of bulge at the junction of the two bones right there. Okay. You learned in the morning that there are 12 thoracic vertebrae. Well, each of those vertebrae has a rib associated with it. They're all attached to the spine posteriorly. All right, so the ribs are all attached to the vertebral column posteriorly. As they proceed anteriorly, they slope inferiorly, and then they go anterior. Now, it doesn't start like that. In a fetus, the ribs are relatively straight, but as it develops and the body grows, it's kind of dragging the ribs down with it, so they take this anterior and inferior kind of course. Only the first 7 ribs attach directly to the sternum, kind of directly to the sternum. They have their own cartilage. So I have the rib here coming from posterior, making its way anteriorly. The rib itself is not what's communicating with the sternum. I have this piece of cartilage that's attached to the sternum, attached to the rib, the costochondral junction here, and then it makes its way over to the sternum. That's the first 7. This is kind of what confuses people a little bit. You see this 7th cartilage? That's the one that's attaching to the sternum down here. The next 3 ribs, 8, 9, and 10, join that 7th cartilage. They don't have separate cartilaginous attachments to the sternum. They need to piggyback onto 7. So that's why they're called false ribs. They don't have their own attachment. They're sharing the attachment to 7, but this attachment is the one that belongs to 7. Lastly, right, we have 12 ribs. We're missing 2 so far, right? Those would be which ones? 11 and 12, right? Not a trick question. So 11 and 12 don't attach to the sternum at all via any cartilage or anything else. They're attached to the vertebral column, but they're floating. They're just hanging out there in the breeze. And they're a little shorter, but you should be able to feel them on most people. And actually pressing on them is a little uncomfortable because you're just pressing on the bone. And this is something we're going to get back to later on as we go into the details of the structure of the ribs itself. The space between the ribs is named by the rib above. So if I pointed to this interspace right here, what interspace would that be? That would be the 5th. Right? That's going to be a very important landmark for doing a lot of things, like listening to heart sounds, placing EKG leads, etc. And it's all based on this. Getting back to what I said in the beginning, if you let this go too far behind, each subsequent lecture is going to exponentially get you further behind if you don't stay up and master the stuff as we go along. All right, next. So we're still looking at the thoracic cage. Now, it has an inlet and an outlet, which are kind of misnomers. There are things that are running in both directions through both of those things. So I could say that the inlet was the superior thoracic aperture, and I can say that there's things that are coming in and out of here, like the esophagus is coming from the neck going down through there, but the aorta and the branches of the aorta are coming out of this and going up to the head. All right, so it's not just an inlet. It happens to be the superior part. Inferiorly, I have another aperture, which people will call the outlet. Right? You have the vena cava running the other way, going up into the chest that way. Okay? So it's not completely an outlet, but it is bounded by the diaphragm all around where you can see this red line attached, and that's separating the chest from the abdomen. Now, take a look at it. What can you tell me about where that diaphragm is located and the fact that I've told you it's separating the abdomen from the chest? True or false? Part of the abdominal contents are within the thoracic cage or bounded by the thoracic cage. True. Right? Things like your liver are tucked up underneath the lower part of your ribs right there. Your spleen on the other side is tucked up under those ribs. And indeed, if you fracture any of those, say in a car accident or something, that broken rib could puncture your spleen or puncture your liver. All right. We're up in there. I want to focus on the sternum for a little bit right now. So we're looking at the very superiormost aspect of the sternum. And remember we talked about the clavicle being attached to this area. And that really is a true synovial joint. It's got a capsule, it's got synovial fluid. It even has its own cartilaginous disc in there, just like a knee. Just like the meniscus in a knee. That's a cartilaginous disc inside of the joint. Because of the stability required anchoring the upper extremity to the torso, I need a robust series of ligaments that are going to help keep this joint intact so that every time I go to lift something heavy, I don't yank the head of my clavicle out of the joint with the sternum. Okay? So you have these series of ligaments both outside and around the capsule, as well as things like the costoclavicular ligament. Here's a secret of anatomy. I'll make you one promise. The less you remember, the less you memorize, the less you'll forget. All right? Just look at what's right in front of your eyes and make up a name. I don't care what language you use. Some of it's in Latin, some of it's in English. There's a ligament that's running from the clavicle to the rib. Costo meaning rib and clavicle meaning clavicle. All right, so that's the costoclavicular ligament. Here's a muscle right here, which is also running on the inferior edge of the clavicle, called the subclavius muscle, running to the first rib. The ligaments are static elements, so they're not going to budge. They're not supposed to give. The muscle, at that point, can contract and support that depending on the load that the upper extremity is bearing. So it's just a little extra mechanism. And what does any of this have to do with the thoracic wall? This is the opportunity to dissect these things. Because when we do the extremities, this will already be dried up and sort of tucked away and destroyed. So we need to be able to identify these things as we're doing the dissection to get into the chest. Remarkably, why does it need so much reinforcement? When you think about it, this is probably the first thing that really truly amazed me in medical school. Was it's the only joint holding your upper extremity to your body. You say, wait a minute, what about the shoulder joint with the humerus and the scapula? That's not anchored to your body. That's out there floating free, and all the muscle and other fatty tissue and whatnot out there. This is the only hard point attachment of your upper extremity to your actual torso. That's it. You dislocate that, you're in trouble. Okay. Now, we talked about joints this morning. Any place where two things are meeting, two bones or a bone and a cartilage are meeting, that's a joint. So I have this synchondrosis. It's not a synovial joint. It's a joint that's spanned by cartilaginous and fibrous tissue where you can get some motion, but generally speaking, not a lot or any, if at all. But it's there for stability. You want to anchor the first rib to the sternum itself. As I go more inferiorly, well, look, here's the angle of Louis, manubrium, body of the sternum. There's the cartilage of the second rib joining that area. That's actually a synovial joint. No disc or anything there, but it's a synovial joint. That's where the motion is happening. That's where the bulk of the motion is happening. If I fill in the rest of the sternum there, I can see that each of these attachments of the cartilage to the sternum is a synovial joint, but I still have these attachments of the rib to the cartilage itself, and each of those is a synchondrosis. This is the costochondral joint. This is the sternocostal joint. Sternocostals are the one that are synovial, between the cartilage and the sternum. The costochondral, between the rib and the cartilage, are all synchondrosis. They're all cartilaginous joints. So there's no joint fluid in there. Why is that important? Anytime you have a disease process that involves synovial joints, every synovial joint is involved. There's a condition called Setzi's syndrome, which is inflammation of these sternocostal joints, right? Not the costochondral ones, because they're not synovial. The sternocostal ones. And it feels like you're having a heart attack. Now, you don't just say to somebody, well, it's just sternocostal pain, go home. You have to work them up, and when the workup for their heart disease is negative, this is kind of a diagnosis of exclusion. All right, but it can hurt that much, and it limits chest motion, so they're not able to inhale. They can't move their rib cage the way they're supposed to. All right. Let's just kind of ghost that in there for right now so that we can get an idea. Like I said, your patients are not going to come in with their sternums exposed, hopefully. So let's just put this in here, and we can note 1, 2, 3, 4. The nipple's in the fourth intercostal space, because I really took great pains to make sure it was to scale. So let's take a look at the surface features themselves, because there are other things that we have to put into context for you to use during your administration of a physical examination. So we know we have the clavicle up over here, I have the sternum, and then I have the costal margin. Now what you may or may not have noticed up in the lab on Friday is that not everybody's costal margin is the same. Depending on the size of the person, that costal margin can be wider and flatter, right? Because this is just that cartilaginous edge of 7, rib 7, with 8, 9, and 10 joining it. That's what's forming the costal margin. That can be spread out like that, or it can actually be rather narrow like this. The only time that really presents a problem is to a surgeon when he's making an incision up in that area. Because with a narrower angle like this, not only is the incision, not only is there less room to make an incision, but once you make it, it's kind of harder to spread things apart. And if you spread too hard, you can break the cartilage. Problem with breaking cartilage is it doesn't show up on x-ray, so you don't know it. Okay, let's go forward. Let's get rid of that line too. And we'll put the jugular notch and the angle of Louis there, and then take the sternum away. So we can see where these things are. You should be able to feel these things. So now when you're looking at your patient, there's the angle of Louis. I know that that represents the anterior part of the mediastinum, the division between the major areas of the mediastinum. And I know above that, between the jugular notch and the angle of Louis, is where I'm going to have these major vascular structures. We'll go into that next week, but I want to start planting the idea now. But we have these lines that are drawn there. Now, I have this mid-sternal or anterior median. What's the difference between median and medial, besides the last letter? Median means midline. Medial is a relative thing. Right? Medial and lateral are relative. You can shift those things. For instance, I could say this nipple is lateral to this line. I can say this A is medial to that line. If I moved the nipple over here, or if I could play around with medial and lateral. Median is in the midline, right up and down the middle. Okay. So now off to the side, I have these lines. These are obviously, these other ones are all artificial. I have a line running through the middle of the clavicle called, again, make it up, midclavicular line. When you start trying to get an idea of where to listen to heart sounds or where to put EKG leads, these are the reference points you're going to use. The such and such interspace at the midclavicular line is where a certain chamber of the heart should be, or where a certain valve should be that you have to listen to. So you have to get a good sense of where these things are. If I kind of turn the body to the side a little bit, obliquely, oblique meaning I'm not turning it. If I was standing here flat against the wall and then turned at a right angle, I'd be at a right angle to the wall. But if I turn it something less than that, I'm just obliquely oriented to the wall. So there's something between a 0 and a 90-degree angle. Having done that, I can see the armpit up here. This guy's arms are up in the air. And I can see this fossa, this indentation called the axillary fossa. Anterior to that, I have an anterior axillary line, and posteriorly, I have a posterior axillary line. As we dissect this, you're actually going to see in the dissector them call these things the anterior and posterior axillary folds. Anterior axillary fold is going to be the lateral edge of the pectoralis major muscle, and the posterior axillary fold is going to be the anterior edge of the latissimus dorsi muscle. Don't worry about that for right now. We're just talking about lines. But right down the middle, I have a mid-axillary line. I'm going to show this to you again, but do you remember the lateral cutaneous nerves that we talked about this morning? Okay? That's where they are, along the anterior axillary line. So if you were to kind of examine each other or yourself in a mirror, you can get an idea of where these things are. Why is that important? Let's say you had to numb somebody up, and you know the dermatome and you know the interspace, and you wanted to inject them with some local anesthesia. You could easily say it was the nipple you wanted to numb up. I can go over here, right? If that's at the fourth interspace, it must be innervated by the T4 nerve. So if I could inject the nerve right at that area where it's coming out from underneath the fourth rib, I could numb up that whole nipple and that whole dermatome just by injecting over here. The challenge is how to use this stuff. The facts are the facts. The thing I always try to answer for you folks is, so what? Who cares? Why do we need to know this stuff? You know? It's how you employ it, which is what Dr. Pravitz referenced this morning, how to apply it. Okay. So now let's look at the chest. We've got the surface landmarks. We know the structure, general structure of the thoracic cage. Now what we have to do is get rid of the skin and the superficial fascia and start getting down to the layers of the muscles. So the first thing we're going to do is peel the skin away and look at the extrinsic muscles. What do I mean by extrinsic? What do we mean by extrinsic? These are muscles that start on the rib cage and go somewhere else. So they're not starting and ending on the thoracic cage. They're starting on the rib cage and going to the arm. Or down, they're running from someplace other than the rib cage to the rib cage. They're going from the rib cage to something else, an extremity, etc. Okay, or in the case of one muscle, from the rib cage to the scapula. Right, so those are extrinsic muscles. So let's take a look at them. So this is what you're going to be doing in lab tomorrow and Wednesday, taking off the skin and the superficial fascia and getting down to this. Fascia has been removed so we can see a little bit more. And we can see the deltoid muscle here, which actually is attached to the inferior surface of the clavicle and then goes around posteriorly and attaches to the scapula. And we'll talk about that in much more detail when we talk about the upper extremity. Again, we need to kind of point these things out to you now because they're in the way. You're going to be cutting through them, so we have to be able to identify them. Medial to that, coming from the medial portion of the clavicle, is the pectoralis major muscle. One of the things that you will be doing in lab is trying to identify this area right here. There's a triangle. The base of the triangle is the clavicle, and then you have the deltoid muscle and the pectoralis major muscle forming a triangle, right? Make up a name, deltopectoral triangle, through which runs the cephalic vein, which you'll be learning more about. But that's one of the things that you have to identify this week. All right, so let's keep going. Let's get rid of that and get back down to the pectoralis major muscle. I already mentioned the attachment over here to the clavicle itself, but it also has an attachment to the sternum as well as to the costal margin down over here. What's interesting, and again, we'll go into more of this when we talk about the upper extremity, but you can see that that inferior part of the muscle actually attaches more superiorly on the humerus than the part that's attached to the clavicle here. And that has functional significance, which we'll put off to a later date. But you're going to see this in the lab. You'll see that that inferior medial part of the pectoralis major muscle actually twists as it goes up into the region of the axilla. Over here, I can see these fingers. You see them kind of pointing down this way? That's the serratus anterior, serrated like a knife edge. And those are attaching to the medial edge of the scapula back in here. So it's an extrinsic muscle going from the thoracic wall to the scapula, and its function is to move the scapula. How? Stay tuned. Here is the nerve innervating that. That's the long thoracic nerve. Sometimes you can identify that at this stage. It's a very thin nerve, and you should take care to identify it. But that's the innervation, and that's prone to injury during certain surgeries up in and around this area. Okay, there's the pectoralis minor muscle. It's attached from the coracoid process here. It's coming from ribs 3, 4, and 5 and going up to the coracoid process. But notice it's enveloped in a layer of fascia. Haven't peeled that away yet. We have to define what that is. But once I cut the pectoralis major muscle away, I can see the pectoralis minor covered in that fascia. The other way to look at that is the fascia covering the pectoralis major muscle is not the same fascia that's covering the pectoralis minor muscle. So let's take a look at it. There's the cephalic vein. I'm going to peel that side of the pectoralis major away. And now I can see the pectoralis minor in its fascia here. The cephalic vein, you can see it's coming. Veins don't branch. Did you know that? Veins are tributaries. They're coming together and forming something. So they go from smaller to bigger to bigger to bigger. So here's the cephalic vein coming and joining the axillary vein right here. All right, that's where it's joining. Now, if I take a look at this cut pectoralis major muscle, I can see that there's a layer of fascia on either side of it. Now, be careful how you mix terminologies. I could say that's on the anterior and posterior surface of the pectoralis major muscle. I could say it's on the superficial and deep surface. But the thing is, anterior is always anterior, and posterior is always posterior. Superficial and deep changes. Okay? Picture going from the body from anterior to posterior. Is the skin on my back superficial or deep? Superficial. So it's posterior, but it's superficial. Why? Because it changes. How far do you run into the woods? Halfway. Because the other half you're running out. Okay? Unless you're running in circles, which is no good either. That's how this works. Anterior is anterior, posterior is posterior. If this muscle were on the back, the posterior part of that would be the most superficial. All right? So again, you have to look at this stuff with a critical eye. Now, let's take a look at a sagittal image, or parasagittal really, right? Because sagittal would be right in the middle. This is off the midline, like I was standing in the doorway scanner and going through this way and taking a slice like this. And you can get a view of the pectoralis major and minor muscle here, and I can see that anterior and posterior layer of the pectoral fascia, or pectoralis fascia. Right? All right. What you'll notice here is as that anterior and posterior layer make it to the lateral edge of the pectoralis major muscle, it kind of comes together, and that's what's forming that axillary fascia. That's step one, because we have to define how everything is going together there. Here I have clavipectoral fascia. Where do you think clavipectoral fascia goes? From the clavicle around the pectoralis minor. All right, take a look at it. Here I can see the clavicle. There's a muscle just on the inferior surface of the clavicle. What muscle do you think that is? Subclavius. Notice that the fascia is coming anterior and posterior to the subclavius. That makes it easy to find the subclavius muscle when we do the dissection. Because once you get the pectoralis major muscle out of the way, all you have to do is incise that fascia, and there's this muscle right there. Easy as day to identify. There's another secret I'll let you in on. You know what the secret to finding things is? Knowing where to look. It really is quite easy. Right? It's not, don't make it harder than it has to be. I just have to know where to look and what layers I need to go to get through to get there. Okay. What you'll notice is the clavipectoral fascia is suspended from the clavicle, comes down and joins together, all right? And then it splits and goes around the pectoralis minor muscle, anterior and posteriorly, and comes together again right here and is connected to that axillary fascia. That's what's called the suspensory ligament of the axilla, this one right here. Why? Because when I lift my arm up in the air, all that stuff is connected and attached, and that's what causes that indentation when you lift your arm up. It's the connection of the suspensory ligament of the axilla to the axillary fascia. Next, you're going to get a lot of lectures on the brachial plexus again with the upper extremity. Again, because we have to go through this stuff first, we have to show you little bits and pieces of it before we give you the whole picture, but that's okay. So these nerves are what's going to innervate the pectoralis major and minor. Now, if I just asked you, and this is the best way to do it as far as I'm concerned, look at the picture and just tell yourself stories. Don't even use grown-up words. This thing is going over this thing to this thing. This thing is going through this thing to get to that thing. All we have to do is fill in the names as a separate thing, but you've described it in a very non-threatening kind of way. So here I have this thing going around that thing to get here, and that thing is the lateral pectoral nerve. It's going through the clavipectoral fascia here, not innervating the pectoralis minor, but indeed innervating the pectoralis major. I have this other nerve here, is the pectoralis minor, and I have this other nerve here, which is going through the pectoralis minor to the pectoralis major, innervating both of them. All right, so the pectoralis major has dual innervation, the pectoralis minor does not. Truth be told, if you take a look at where this nerve is coming through that muscle, right there's the long thoracic nerve. Okay, if you take a look at this nerve coming through the muscle, sometimes it doesn't come through as one nerve. Sometimes it comes through as multiple nerves. So if you see multiple nerves coming through the pectoralis minor and going to the pectoralis major, which one of them is the medial pectoral nerve? Starts with an A. All of them. Okay? Because they fit the criteria. So you'll see that. And then here's that long thoracic nerve innervating the serratus anterior muscle. Let's talk a little bit about the blood supply to the anterior chest wall. So here I have the first rib, and if I drew, like I said, if I drew a line around the top of the first rib over the top of the manubrium, that would be the thoracic inlet. And I can see the subclavian artery here having emerged from posterior to the manubrium, right? There's the angle of Louis. It's coming out, going up above that, coming out of that thoracic inlet and then diving under the clavicle, between the clavicle and the first rib right here. Before it does that, it gives off this branch, the internal thoracic artery, which you probably have heard about before, but it was called the internal mammary artery. If you read clinical studies and whatnot, they still use the older terminology in a lot of these things, and there's just no way around that. Some things will never change. You know that as well as I do. So terminology is one of those last things to go. But the last thing I want is for you to say, somebody to say to you, internal mammary artery, and you're going to say, well, we never learned that. And they're going to say, well, who taught you that in anatomy? And I don't want you giving them my name. Okay? You have to know both, because they will be used interchangeably. But we're only going to call it the internal thoracic artery here. Now, you can see from both of these pictures, again, once you start piling on adjectives, it can get confusing very quickly. That's on the posterior aspect of the anterior thoracic wall. Or you could say it's on the deep aspect of the anterior thoracic wall. And you can see it's giving off branches. Okay, next step. Once the subclavian artery passes the inferior border of the first rib, it changes names. It's like a highway crossing state lines. Over here it's State Road whatever, but now you're in a different state, so it's State Road something else. Where'd you turn? You didn't. You just kept going straight and you crossed an imaginary line. Same thing with this. So once it crosses the lower border of the first rib, it's the axillary artery. Same conduit. As we go further down into the axilla, we can see this lateral thoracic artery, which for all intents and purposes is at the lateral edge of the pectoralis minor muscle. These vessels can be very small and very difficult to identify. I want to bring your attention at this point to this guy right here. In the dissection manual, it says not to identify that. That's the thoracoacromial trunk. I didn't even label it because I don't want you looking at it. Look at it and don't look at it again real quick. Okay? Because to do that, you have to dissect the axilla and disturb all the structures in the axilla, including the brachial plexus, and you'll have destroyed everything in search of something that's really not that significant and ruined everything else that's really important. So we're not going to be dissecting the thoracoacromial trunk until we do the extremities. All right. Now let's take a look at the deep surface or the posterior surface of the anterior abdominal wall. Now here I can see the subclavian artery and the branch of the internal thoracic coming down on either side of the posterior aspect of the sternum. Now, when we look at these things, bundles of things, it would not be appropriate, especially as the bundles get smaller, for us to ask you which one was the artery, which one was the nerve. Frequently we'll bind them all together and say what nerve is in here, what artery is in here. So if I can do anything to put your mind at ease today, let that be one of them. Right? This is not about tricking you, like Dr. Rettlinger said this morning. Our goal is to help you succeed and give you strategies to succeed. Next, I can see from that internal thoracic artery, I have a branch running on the lower edge of the rib here called an anterior intercostal artery. I'm going to go into more detail about the significance of those later in this lecture, but let's start with this here now. Then, posteriorly, I have an intercostal artery, which is coming off the thoracic aorta, and you can see the thoracic aorta at that point is not right in the midline, is it? Which side of the vertebral column is that lying on? Left side, right? Because you're looking at the patient, left is right, right is left. So you can see that that posterior intercostal artery on the left has to cross over the vertebral body to make its way to that interspace to run with its corresponding nerve. Again, you have an anterior circulation and a posterior intercostal circulation. And this is just one chance to show you the first of the intrinsic muscles we're going to be showing you. Why is that intrinsic? Well, it's starting on a rib and it's going to the sternum. Its role is to help pull the sternum back when you're exhaling. So when you breathe in, your chest expands. And now this is one of the things that helps pull it back into place as you exhale. That leads us into this. Now we have to talk about the intrinsic muscles, which are starting and ending on the thoracic cage, so they can go from rib to rib or rib to sternum, right? But we have to define the details of the ribs first. We looked at the general structure, 12 ribs, how they slant down towards the sternum, what their connections are, etc. Now let's take a look at the details of the ribs themselves. Again, this is the kind of thing that seems counterintuitive. The proximal end of the rib is posterior, where it attaches to the vertebral column. That's the proximal end of the rib. Proximal end of the rib is in your back. As we proceed from proximal to distal, the distal end is what's articulating with the sternum. So if you were to feel your angle of Louis and say to yourself, yeah, I know, manubrium and sternum, old news, last week, I'm keeping up to date. But that's where the distal end of the second rib is. All right, so proximal is posterior, distal is anterior. Usually if I ask that question beforehand and in years gone by, everybody says, well, the anterior part is the proximal part. No. Anterior is distal. So let's take a look at a rib the way it really is. Here's proximally. It's curving around, going anteriorly, and then it's attaching to the sternum at its distalmost extent. Now we have to put these parts into context. This is all leading up to what muscles are there and how they work. But we have, just like we did with the extrinsic muscles, we defined the skeleton first and then filled the muscles in later. Okay. So I have two facets, a superior and an inferior one. That's what's articulating with the bodies with the vertebral bodies in the thoracic region. Okay. So then I have a neck leading out to a tubercle and an articular facet for the transverse process. Guess what that articulates with? Transverse process. So I have three spots where the proximal end of the rib is going to articulate with the vertebral column. Two parts with the actual body of the vertebral body, with the vertebral segment, and one part that's going to articulate with a process coming off of the vertebral body. So we have to define those things too, just so that we know how it's arranged. As I go further distal, I'm going to come to an angle where it kind of comes over here on the side and makes its curve anteriorly. On the deep inferior surface is a groove where the neurovascular bundle runs. The groove is actually made by the pulsation of the artery in there, just kind of cutting its own groove in the bone. But it's kind of protected anteriorly. I shouldn't say anteriorly, superficially, right? Because this is posterior. Posterior, and now this is posterior on the inner surface. So this is where you might prefer to use deep and superficial as opposed to anterior and posterior, because the thing is constantly changing orientation. And then you have to know if that's a right or a left rib. Let's just stop right there. You have to orient it as if you were the person whose rib this was. So if this was your rib, would you be standing with your face facing the screen or facing the back of the room? Facing the screen. All right, because here's posterior. So is this a right or a left rib? It's a left rib. Right, because now you're looking at the person from posteriorly. So left is left and right is right. And you should be able to do that. Part of what I'm doing with this is that there's a part of the lab that you have to do this week where you have to go up and actually handle the bones, pick it up, take a look at it, identify the parts of the vertebral bodies, identify the parts of the rib, understand if it's a right or left rib, etc. All right? No matter how we did this, there's no substitute for going up in the lab and doing it. That's the beauty of this course. You have that extra step where you can take all of this stuff and physically, not just look at it, you can physically do it up in the lab. Okay, now let's get back to the vertebral segment itself. We have a body, which we've been talking about, and then or pedicles that the body is standing on. As I have defined the parts of this canal, right, that's where the spinal cord is going to run through. As I have the parts of that canal, as I come off the pedicle, I come to this lamina. So you can see that whole arch is formed by two pedicles connected by two lamina sitting on the vertebral body. Now, I have these projections coming off. Where the pedicle meets the lamina, I have a process coming off transversely. Remember there was an articular facet for the transverse process on the rib? There's an articular site right there where the rib's going to sit. Where the two lamina meet, here and here, coming from that is a spinous process. That's what extends directly posteriorly. Next, I have a superior articular facet, and I have an inferior articular facet. That's where the head of the rib is going to articulate, but not the way you think. I'll show you how that goes, because that's going to be two separate ribs attaching, one here and one there. We have to kind of stack things up, and I'm going to show you how that happens. Then we have the articulations of where one vertebral segment meets the next. So I have there's the transverse costal facet, and I have a superior articular facet, and down here I have an inferior articular facet where I can kind of, like Legos, I can kind of interlock them and stack them up. When we get to the back, when we do the extremities, the angle of these, see how that's facing posteriorly and that's facing anteriorly? They're kind of flat facing you. Like, so my thoracic vertebrae, my superior articular facet would be facing like this, and my inferior facet would be facing you. When you get down into the lumbar region, they're faced side to side. So just by looking at the way these facets are angled, you can tell what segment of the vertebral column it comes from. It's not something we expect you to do now, but it's something you will be expected to do eventually. Okay, so how do we put these things together? Let's take a look at the pedicle first. So here I have the pedicle attaching the body, and I can see a notch on top of the pedicle and a notch inferiorly on the pedicle. As I stack these together, those notches are going to come together to form windows, foramina. So if I take a vertebral body like this and just show you where the inferior articular process is here, I then want to stack those up like so. So I take the superior process like this, and now I have a vertebral column. Cool, huh? Not the end of the story. Take a look at this. See the superior vertebral notch here? That becomes the inferior part of that window. See this inferior notch here? That becomes the superior part of that window. You can drive yourself crazy with orientations and whatnot, but this is why it's important to do this on the fly, not waiting until the last week or waiting until a couple of labs go by. So this is the kind of stuff you should have down cold by the first lab. Now, I'm going to put a disc in there between the vertebral bodies so that I can now make an actual window like so, and that's the intervertebral foramina where the spinal nerves are coming out. So take a look at this. If that disc herniates, guess what it's going to be pressing on right there? That's what happens. That's how herniated discs and sciatica and all those things work. Okay, so now let's start putting stuff together. So there's a representative thoracic vertebral segment. And I have two ribs. Now what I have to do is take those two ribs and put them together in such a way that they're articulating with these facets as well as that transverse costal facet. Okay? Like so. Now you can see that this inferior articular facet is articulating with this superior costal facet, this superior facet with that inferior one, right? Now, if I keep on talking like that, everybody's just going to give up, right? It's only day one. I don't want to do that to you. So what I'm going to do is put another vertebral body in there just so that you can see how it actually comes together. This is the kind of thing that you should physically do up in the lab and tell yourself the story as you do it. If you have trouble telling yourself the story, there's computers up in the lab. Pull this lecture up on the computer and look at it while you're holding the bones in your hand and make it come together like this. So if this is T10, right, that's the 10th thoracic segment. Which one of these is the 10th rib? Is it this one or is it that one? Got to choose. Quick. Which one is it? That one. Okay? And if you take a look at it, you can describe this any way that makes you feel comfortable. There's no one way of doing it. Whatever part of the rib is articulating with the transverse process, that's what it is. To me, that's the easiest way of doing it. Or you can go into, well, the inferior part of the head of the rib with the superior part of the vertebral body, that's the segment it belongs to. Yeah, they both work. And there's no variation with that, so you don't have to worry about it. All right, but this is how you, so this, if this is the 10th rib, what interspace is that? 10th, right? Okay. So the next thing we have to do is to take into consideration how these ribs are moving. So I can see that, now that I've showed you the architecture of it, all these are covered with ligaments and everything else reinforcing these ribs. You can't see these joints. And these, again, are all synovial joints. What we have to do is take into consideration the fact that these costal facets here are shaped differently depending on where you are, superior to inferior, along the thoracic spine. And that the axis of rotation is going to be like this through there. So those ribs are going to rotate. And they're not free to rotate, because remember, I have a connection posteriorly to the vertebral column and a connection anteriorly to the sternum. So it's not like this rib is just free to move. All it can do is flip up and down because it's anchored. It's like taking something like this, a weighted string between your hands and just swinging it back and forth. It's not a whip. So what we have to do is, again, we talked about illnesses that can cause inflammation of the joints will produce difficulty breathing, arthritis, anything, rheumatoid arthritis especially. The majority of the respiratory effort is controlled by the diaphragm. Diaphragm moves down, you inhale, diaphragm relaxes and goes up, you exhale. Right? Old news. It's something you should be well aware of. How much does the thoracic cage contribute to that? Well, when I inhale, my thoracic cage gets wider, and when I exhale, it gets smaller. Right? You're kind of pushing air out, kind of, sort of. But it's the combination of all this. And really, the function of the intercostal muscles is rather controversial. So let me just give you the basic concepts here. If we take a look at the motion of the upper ribs, if this were, say, where the rib was attached posteriorly, and here's the attachment to the sternum itself, picture grabbing onto this handle and pulling up on it like I'm working a water pump, like so. And that's where it's pivoting. And this is that joint posteriorly over here, where I can see, because of the shape of that facet, it allows for this rotational kind of motion, which allows for, if I take a breath in, it would be like me taking my sternum here and pulling it forward and up. And to exhale, I'd be pushing it inferiorly and posterior. So I'm pulling it out and up and then pushing it down and in. So that's the pump handle mechanism. And that's usually what is responsible for motion in the upper part of the rib cage, the true ribs, not the false ribs or that kind of thing. Once I get down to the lower aspect, you can see that joint is flatter. So it allows for more of a gliding kind of motion, which accounts for the ribs just kind of flaring out to the side like this when you breathe in and you breathe out. And it's described as a bucket handle kind of motion in terms of the motion of the rib, not the motion at the joint. But it's kind of pulling it up and to the side, flaring out. The combination of the two increases the lateral dimension of the thoracic cavity and the anterior-posterior dimension of the thoracic cavity. Okay, so like I said, this is controversial. Now, describing how these muscles run can be very cumbersome because you have something that's changing from posterior to anterior. You're going from medial to lateral to medial. And if you try to describe it based on those terms, you're constantly changing your point of reference. So everybody here take algebra? Just say yes, because you had to get here. All right. I didn't ask if you passed or what your grade was. You took algebra. That's all I care about. So when you get a polynomial equation, what's the first thing you do? What's that? Like terms, right? You eliminate like terms to get down to the smallest number of variables. But if you're constantly dealing with a changing direction, medial to lateral to medial, you're constantly introducing variations. From here, that muscle might be running medial to lateral. Here it's running posterior to anterior, and here it's running from lateral to medial. So you have to know where you are. So let's just get rid of all that, because I say so. Right, this you're not going to find this written anywhere. This is the way I look at things, and I look at just about everything differently. Okay, so what I'm going to do first is I'm going to show you the proximal end of the rib and the distal end of the rib, just like we've done before, right? Because the distal end is by the sternum. Now I'm going to drop a perpendicular. How's that for it? You never thought you'd hear that again, right? There's a perpendicular line. I'm going from the same point on this rib above, Same point on the rib below. Everybody agree with that? Ostensibly, anyway. It's kind of curved, so it's kind of hard to say. But notice I'm showing two random ribs. And I'm starting at the first rib and going down, not the 12th rib going up. So it's because this is my system, and that's how I want to do it. All right, so we're going from the rib above to the rib below. That's the first part of it. So you always have to say it out. Don't take shortcuts. Starting at the rib above. These muscles are running at a right angle to each other, so to speak. Okay, let's take this one first. That's the external intercostal muscle, responsible largely for inspiration or inhaling. And if I described how it gets from the rib above to the rib below, I would say it starts proximally at the rib above and runs distally to the rib below. See that? Now, I don't care. And now I could move this over here. It's still starting more proximally than it's ending distally. And that's the same. It's like I took the rib cage. You know who Ridley Scott is, right? Who's Ridley Scott? Directed Aliens, right? So when that alien bursts out of your chest and straightens your ribs out, okay, your rib's now straight, but guess what? This is still proximal and that's still distal, whether it's like this or like this. So let's just think of it as a straight rib. So this is running proximally from the rib above, distally to the rib below. So then how would I describe, all right, well, and it, like I said, remember the external intercostal muscle layer doesn't go all the way anteriorly. It kind of ends here and then continues as a membrane, watch, right there, to the midline. All right, so the muscle doesn't make it all the way to the chest. Now let's talk about the other muscle here. If I had to describe that internal intercostal muscle, I'm starting at the rib above. I have to start at the same rib in both circumstances, otherwise I've introduced another variable. Here it's going distally from the rib above, proximally to the rib below. That's it, done. Now, they're virtually perpendicular, and at this point, because of that external intercostal membrane, I can actually see the internal intercostal muscle through it. So if you're looking just lateral to the sternum, you'll see an intercostal muscle. But if you look at the direction of the fibers, you'll notice from the rib above, it's running proximally to the rib below, right in there. Now, there's all sorts of theory about what these muscles do and that they change function at this because of the... Forget about that. External intercostals inhale, internal intercostals exhale. More than likely what they're actually doing is they play some role in that, but they're stabilizing the interspaces at different parts of the respiratory cycle. Okay? But that's what they do. What are they innervated by? Those intercostal nerves that we were talking about, which I'll show you in a little bit more. So let's take a look at sort of a composite cross-section of the thorax at this point. Here I have another layer, the innermost intercostals, and I would describe their direction the same way I did the internal intercostals. Distally from the rib above, proximally to the rib below, but it's not a complete layer either anteriorly or posteriorly. I should say anterior here and posterior there. I had it backwards. It's complete neither posterior nor anterior. Posteriorly, it's connected to the proximal part of the rib by this internal intercostal membrane and then travels this way. Now, in grants, they'll tell you that you can dissect that. I say you can't do that. They're too thin. There's only one way you can really take a look at that muscle and be assured that it's the innermost intercostal muscle. How is that? Got to use your imagination. It's time to jump outside the box and look into the darkness and see me staring back. You got to do it from the inside because that's the innermost layer. So it would be like saying we're standing in the chest here. That's the innermost intercostal. To get to the internal, I'd have to peel that away and get behind it. So again, you have to start thinking in those kind of terms. As we go more superficial, I have this internal intercostal muscle, which again is attached to that internal intercostal membrane, but it does make it all the way to the sternum, which I showed you in the last slide. I can see through that. Here's the external intercostal, which is attached completely posteriorly, makes its way through the interspace, but doesn't make it all the way through, all the way anteriorly, and then I have that external intercostal membrane through which I can see the internal intercostal muscle. Is that it? No, never. Here I have that intercostal neurovascular bundle, which is running between, look, they actually cut a little window for you here. Okay? But take a look at the direction of those fibers. Here's the rib above, there's the rib below. This is more proximal. It's running distally from the rib above, proximally to the rib below. It never fails you. It never fails you. But it's running between those layers. And in grants, they'll say, if you dissect between those layers, you'll find these things. It's impossible to identify them as separate layers in a cadaver. But there's a special trick that we have of being able to show you them. And when we pull it out from under the rib, from that costal groove that I showed you, you can't necessarily tell which one is which. So again, don't worry about that. We have to find it. We have to know where it is. We have to know what three components are there. But identifying which one is which, in a drawing, we could show you the three things lined up, and you should know what order they are. But in a cadaver, that's difficult to do. In a picture, it's easy to do. And I can see them running between the internal and the innermost intercostal right there. But look at this. Here's, what vessel is that? Again, here's what you can't do. When I ask you a question, you got one job. Don't answer it. That's it. Simple, right? It made medical school very easy for you. Think about it. Look at what's right in front of you. Start naming things in a ridiculous kindergarten kind of fashion. I see this vessel. Where is it? It's inside. Don't use fancy words. It's inside. Inside what? The chest. Now give me a fancy word for inside and a fancy word for chest. How hard was that? Right? Everything else in anatomy is like that. You just have to understand what you're looking at and break it down into simple terms. And as soon as you say one thing that's on the track, it's like a series of dominoes. Everything else just kind of falls into place rather quickly as you get more and more used to it, if you've done your homework. So internal thoracic, that would be the anterior intercostal, posterior intercostal. But let's take a little bit closer look at that. There's the aorta, thoracic aorta, and the posterior intercostal. Here's the internal thoracic artery and the anterior intercostal, and it comes a point where those two circulations are butting heads. So what happens if you need a cardiac bypass and you say, you know what, they used both my internal thoracic arteries to do it? Does that mean that this section of your chest wall has lost that blood supply? No, because of these series of anastomoses, these connections right here, these collaterals, the capillary beds mix. And if you take the pressure gradient away from one side by removing this blood will then fill this vessel by these capillaries that sort of dilate up and then will, in a retrograde fashion, fill that blood vessel and supply everything that it had. And there are many systems like that in the body. Okay. There's an anterior and posterior intercostal artery. There's only one intercostal nerve. Right, because everything's coming from the spine. So I can see it coming out of that intervertebral foramen here, okay? And then it's running in that costal groove, making its way around between the internal and innermost intercostal. And I can see along that mid-axillary line, that lateral cutaneous nerve coming around, supplying that dermatome. Those are usually actually pretty easy to find when you dissect the serratus anterior muscle. Okay. Lastly, let's just put the issue of the blood supply to the anterior chest to rest. If I look at the arterial blood supply, I have the internal thoracic artery with its mammary branches. The breast tissue is a structure in the superficial fascia of the chest wall. It's really a modified sweat gland, developmentally and actually. When I would do breast biopsies, I'm a general surgeon by training. When I would do breast biopsies, there were some people, if you used the cautery to cut through the breast, it would smell like you were burning perspiration. It did have that kind of a smell. Not in everybody, but in a significant number of people, which is testimony to the fact that it's a modified sweat gland. So if I take a look at this, I can see blood vessels coming out through the pectoralis major muscle, making its way to the breast. And I can see other vessels like the lateral thoracic and the lateral and its lateral branches supplying the breast here, as well as, I think it was my ID card, branches from the posterior intercostals on the inferior edge there. And they all bleed quite profusely if you don't manage them surgically. The venous drainage, whenever you think venous drainage, you should always think lymphatic drainage as well, because the lymphatics are following the veins. So in a situation like this, knowing how to do a breast exam becomes very important. It doesn't matter how you do it. You'll see people do circles, quadrants, etc. As long as you pick a way you feel comfortable doing it, and do it the same way in every patient. It doesn't matter how you do it. It has to be systematic and it has to be reproducible. Okay? So generally speaking, what we do is divide the breast up into quadrants. Upper inner, and then I have lower inner, lower outer, keep going, there you are, and upper outer. And you'll notice that in the upper outer there's this little piece that goes up into the axilla. That's the axillary tail. Axillary tail of Spence, actually, is what it's called, but don't worry about that. So when women are going through their menstrual cycles, they might get some discomfort in their axilla. Well, that's because a piece of this is extending up into the axilla. Okay. The other thing we have to take into consideration is lymph node drainage. I can get some lymph node drainage, which means tumor spread, from the upper inner quadrant to these nodes behind the sternum. Usually, clinically, those are things that we don't have to worry about. And the purpose of taking lymph nodes out is not to treat the disease, it's to stage the disease. How far has it spread? And you'll see various and sundry ways of doing it. I have my preferences, other people have theirs. The point is you need to know the anatomy before you can decide on which one is best for you as a surgeon or as an internist doing a routine breast exam on a patient. Okay? So what we do is we actually follow the lymph node drainage into the axilla. And based on where you are relative to the axillary vein, you can have nodes in level 3, which is more lateral, level 2, which I'll tell you is right behind the pectoralis minor muscle, and level 1, which is medial to the pectoralis minor muscle. The lower the number, the further it has spread. So lymph node spread to level 3 is not as bad as spread to level 1. And then if you spread above the clavicle, that's considered disease outside the local area. We're not even going to talk about that right now. The other thing to keep in mind, lastly, last slide, is that this is the breast in the superficial fascia, right? And it's showing various different, most of the cadavers upstairs will be like this. Postmenopausal women where the breast tissue has been largely replaced by fatty tissue. And I can see all the connective tissue running through there, which as people get older gets more lax and will cause breasts to sag, etc. But that's why, because these structural ligaments, Cooper's ligaments, are relaxing. But here I can see the pectoralis major muscle. There's the posterior layer of the pectoralis fascia. That's the anterior layer. And between the breast in the superficial fascia and the anterior portion of the pectoralis fascia, there's a potential space. It's not a real space, but there's just this very slight bit of fat and connective tissue, which is easy enough for you to be able to put your hand behind and slide right underneath or right posterior to the breast. To do a true cancer operation for breast disease, if one were to say to do a mastectomy, you'd actually have to remove that space with the anterior border of the pectoralis major fascia, so that you'd strip the muscle clean, because that's the path of lymphatic drainage. Dr. Larea is going to use this slide, which I told him he could use when he talks about this kind of stuff when he does breast tissue. So just make sure you're familiar with this. All these other things that you're going to see here, probably not going to identify in the cadaver because it's a cadaver specimen and they're postmenopausal women, and most of these structures have regressed anyway. Okay? Retromammary space, and we're done. Take about a 5-minute break, and then Mr. Bender will talk to you about lab safety.